Good afternoon. Welcome to the National Centre for Disaster Medicine and Public Health. Today, we're delighted to host a webinar featuring Dr. Thomas Kirsch, the Professor and Executive Director of the Centre, and Dr. David Callaway from Team Rubicon. They will be discussing the impact of Hurricane Dorian on the Bahamas. Over to you, Dr. Kirsch.
Greetings, everybody. I think everyone's aware of the devastation of Dorian as it passed over the Bahamas and then sat there for a few days. But I don't know if people are really aware enough of the extent of the damage. So we've invited Dr. Dave Callaway, who's the medical director for Team Rubicon, who has deployed a team to the Bahamas early and is responding now, period. I want to give a little background about the National Center. The National Center was founded about 10 years ago under a presidential directive and is an interagency supported center in the federal government whose mission is to lead efforts in disaster health and public health science and education. We have, in the past number of years, become much more active in the actual response world and are therefore working to spread the message of the importance of this very critical activity to everybody. Dave, would you like to make a few comments about yourself and Team Rubicon?
Absolutely, Tom. Thanks for having us on. It's really an honor to be here. So Team Rubicon first is a disaster response organization that was founded in the aftermath of Haiti by two Marine veterans, Jake Wood and Will McNulty. And it's a veteran-run organization that is comprised of about 100,000 volunteers right now across the nation, 70% of which are veterans or current active duty, and 30% are civilians who've never served in the military but have depth of experience in first response and in other critical areas. Over the last 10 years, we've responded to over 400 disasters domestically and internationally. And our core operations are broken down into domestic missions, which are largely related to debris management, route clearance, damage assessment, and then international missions, which are in coordination with the World Health Organization and are primarily medical. And Dorian is a unique opportunity for us because we've merged several of these mission sets, and it'll be interesting to talk about it. I'm a professor of emergency medicine down at Carolina's Medical Center and the chief medical officer of Team Rubicon, and I've been with them for about 3 years. And we've got an awesome team of physicians and medics and nurses and ops support who are really engaged in this process. So it's a great group, and we again really appreciate you having us on, Tom.
Great, thanks, Dave. Can you give us just a brief background of what Team Rubicon's response has been so far to this event?
Absolutely. So we have always leaned in pretty heavily with a key focus on speed in our response. So going and trying to be the first to a disaster and going to places where other people either can't or won't go. And so in the case of Dorian, we activated our process a few days before Dorian was even at the Bahamas. And our standard process is we have a watch center that's at our NOC, our National Operations Center in Dallas, and they're kind of watching global threats at all times. And when we identify something that we think is going to have impact, we issue what's called an ISR, or Initial Situation Report. So we issued our ISR on August 28th and basically authorized 2 different mission sets. And the first was a recon team or advanced team for the Bahamas. And then the second was a series of domestic missions in Florida, Georgia, South Carolina, and North Carolina in anticipation of Dorian's landfall. And one of the unique things we did domestically in this particular mission is we forward staged our responders where we thought we would see the areas of largest impact. And basically, the idea was instead of working out, we're in after the disaster, we would have these specialized teams in the heart of the disaster who'd be able to work from the inside out to meet other responding agencies. So that was our initial response. And then with the Bahamas, we deployed our Admon team on August 31st, and we're on the ground September 2nd. You remember, basically landfall was around September 1st. So our teams were on the ground pretty early in the aftermath.
So when your teams arrived, I assume it was initially a kind of a scout team you sent out. What were their first impressions?
Yeah, so, and I think it's worth having a conversation about the balance of speed versus country autonomy. We, in the past, in our early days, were participated more than we would like in this idea of self-deploying. And now, as a WHO verified team, we work in close coordination with the WHO, PAHO, and the local ministries to get access to countries before we deploy any significant assets. Our advanced teams, though, have 4 to 6 people, usually a doctor, a medic, and then some other specialists, so that we can establish relationships, make sure that we do a proper needs assessment and coordinate a response. And what our teams found is there was massive devastation across Grand Bahama, Abaco, to a lesser extent, in Nassau, but in the immediate aftermath of the storm. So basically, while the storm was hitting through day 3 or 4, it was pretty much utter destruction. Communication capabilities were out. Transportation and access was exceedingly limited or non-existent. Water was a major hazard and environmental threat everywhere. And there's massive need. To that end, though, what I would, just to give some accolades to the Bahamian government, they did, from what I can see and from my conversations with our team, did an excellent job evacuating people with chronic diseases early. They know every dialysis patient in the Bahamas, and they had most of them either in Nassau or evacuated to Florida. They knew all their sick people. They got them off the peripheral islands. They pre-stocked all of their healthcare clinics in June, which is a standard process for them to do that sort of pre-hurricane season. And so a lot of the healthcare facilities were less affected than the homes and the community centers. And they also tended to have a good deal of pre-stocked material. They did run out of, they had some limitations on chronic medications, but I think the Bahamian government did some great work leading up to this storm.
Thanks. Every disaster is different. We learn lessons from each one of them. This one to me is frightening in that this was way more than your usual hurricane. The power of this event and the fact that it sat over the Bahamas, looking at the damage just from the pictures I have from a distance, the wind damage was equal to that of a fairly forceful tornado, it appears. And the storm surge seems to have been so significant that it washed away even what were considered hardened concrete buildings. Is that what you guys found on the ground? Yes, is the answer. And I shot you guys some pictures, but what we found of interest is there were certain structures that withstood relatively well, and the hospitals and clinics, their construction seemed to be superior to a lot of the other buildings around. So our teams would basically go into a community and do a brief community structural assessment and health assessment, and the vast majority of the island of Abaco had been evacuated, and so literally, it looked like carpet bombing of the neighborhoods. The houses were all destroyed, and they would come to a clinic, and the clinic would maybe have some damage to the roof, would have some flooding, but structurally, with all the clinics that we assessed on Abaco, structurally were pretty well intact, which again is a testament to some of the planning that they were able to do, and hopefully during the rebuild they're able to figure out how to scale that. But absolutely, the communities were completely devastated. So it's been over a week, almost 10 days, I guess. What are the biggest needs at this time that you've been recognizing? I mean, from a medical standpoint, it's really interesting. Our teams out in Abaco did a bunch of clinic assessments, and because of both the preparation and the fact that they evacuated most of the people from the island, the acute medical needs on Abaco are very low. The clinics are still seeing chronic conditions. They have some gaps in chronic medications. They're still doing some medevac, but when we talk to the providers, their response is, we always do medevac
because we're an island. And so they're doing, 1 to 2 a day on Abaco. When you move to Grand Bahama or to Nassau, what we've seen is Grand Bahama's facilities, their fixed facilities took a little more of a hit in terms of flooding and some structural issue. And then because they've evacuated people to Freeport and to Nassau, you have these camps that have been established for basically IDPs, internally displaced people. And what I suspect is going to become an issue, we all know that when standing water is around for a long time, that is a major infectious disease risk. And when we displace populations for any period of time, that becomes a major infectious disease risk. And I suspect that we're going to start seeing some infectious disease outbreaks, or they need to at least be prepared to be pretty aggressive about it, because I don't think anyone's going back en masse to Abaco within the next week or two, just given the level of devastation.
You mentioned that they've actually gathered people in the camps. Can you describe some of these camps? What's the condition like, the housing, water availability, things like that?
So our teams we only have one person who's been to the camp in Nassau. We finished up our assessments and our clinical care on Abaco, and then at the request of the Ministry of Health, we were redeploying our EMT mobile team to Nassau to actually provide care in the camp. And as you probably are aware, there's a weather system over the Bahamas right now, so they canceled all flights and actually canceled all boats. So our teams haven't gotten to the camp yet. So I can't comment on what they're like. I can tell you that their last estimate I had was last night, there's about 2,000 people or 1,900 people. And I haven't seen any other assessment of the camps yet.
That's very unusual for a hurricane to actually have camps. That really speaks to the level of destruction of this one.
Absolutely. And that, again, it was for the Bahamas somewhat fortunate that it took a northerly turn, and so it didn't hit Nassau, and so they have an island that actually had some damage, but it was relatively unaffected, where they can actually move their citizens.
Yeah, I mean, FEMA or OFDA is reporting that up to 5,500 people have been evacuated from outer islands and gathered into camp-like settings, with estimates as high as 6,000 or 7,000.
Yeah.
So
that would go with our observation, and they basically, from Abaco, there's been the discussion of mass evacuation of all people in Abaco since probably the 9th. So they've been thinking about this and planning this. But yeah, those numbers sound about right based on what our teams have seen when they go to communities in comparison to the baseline population that's supposed to be there.
Can you describe the organization of the international response and the Bahamian government's role in that?
I can. So
you can be diplomatic.
Yeah. Well, I mean, we know, right? So one of the biggest challenges is coordination. And anyone who's on the line who has responded knows that, in particular, coordinating a response that's close to the United States is even more difficult, because there are a lot of people who have vacation homes there. There are a lot of people who have their own private jets. There are a lot of organizations that quite quickly can get down there. And so the coordination piece becomes a huge challenge. One of the advantages I think that we have here, because we do so much domestic operations, is when you respond to a disaster in many parts of the world, the WHO and the international framework likes to have this cluster system, which has advantages and disadvantages. The Bahamians have trained and prepared much more in a U.S.-based ICS structure. So they actually have ESF. And so our teams are able to fold in on ESF 8 from a medical standpoint. And then because we do so much incident management domestically, we're able to augment some of the other ESF. So the way that my understanding of the way that the organization has worked is the PAHO and the Ministry of Health have been having health-related meetings under the guises of ESF 8. And then there's a broader EOC that's been basically managing all the other ESF emergency support functions. And so within the medical piece of it, there have been several challenges. One is access to areas. 2 is understanding who is all in the field and providing care. 3 is relaying of information from the field to the ESF8 coordinating cell in order to have accurate tasking of resources. And then 4 is sort of the ability to have operational control of all the different assets that are in the field. I think, again, there has been very good government-to-government coordination. So Bahamian government with the British Navy, with Offset USAID, and with the U.S. military assets and Coast Guard. I think maybe even some DEA assets down there. I think there's been good tactical collaboration between private-to-private groups or NGOs and people with private assets, like their own plane, their own boats, their own warehouse. I think the challenge has been the coordination between NGO and spontaneous volunteers and the Ministry of Health ESF8 desk. Was that confusing enough? Or?
Well, yeah. So let me. That was great, but let me de-jargonize for those who aren't familiar with all the acronyms. You're sounding like a DoD guy. So ESF8s relate to the health response. It's each cluster coordinates different responses. So there's health, and shelter, and water, and food, and things like that. And ESF8 is health, and so Dave's referring specifically to the health clusters and their response. One of the problems that we noted in the past, particularly in Haiti, was because of the proximity of the U.S. that on the ground we were just entirely overrun with people who had really great intentions, but had no skill set, supplies, training, or anything to enable them to be there and provide successful services. And literally dozens and dozens of quote unquote non-governmental organizations showed up. Are we seeing that in the Bahamas?
I think we're seeing a variation of that. My impression from the daily conversations with the team is there are less random groups of people just showing up in 10s and 15s and 20s. There are a lot of organizations showing up, there are a lot of organizations showing up, doing work that may or may not be good. Again, I give everyone the benefit of the doubt. And just potentially creating confusion, though. For example, if the Ministry of Health tasked the team to go do a health assessment on a clinic in Cooperstown, and there's another group there that says, "Oh no, we're an NGO and we got tasked too," when in fact they didn't get tasked. The people there are wondering why the Ministry of Health is tasking 2 teams to come assess them. So the local providers lose faith in the Ministry of Health, and then the NGOs lose faith in the coordinating body. And so it creates some interesting dynamics. But I think it is certainly, having been on the ground in Haiti for a while, it is certainly nowhere near the chaos or the unprofessional spontaneous volunteerism that we saw in Haiti. I think the Bahamians are doing as good a job as they can to grasp the groups that are coming in, to make very stringent customs requirements. And I think that they're doing actually a pretty good job. Just to give them another tip of the hat, Tom, so if you're a U.S. NGO deploying internationally, one of the biggest nuts to try to crack is the transportation of narcotics out of the country. And this is a WHO requirement. If you're deploying as a verified team, you have to have narcotics with you for pain management and controlled substances. And the DEA has a process that takes a little while to do that. And what the Bahamians said, and probably for various reasons, but they said, do not bring narcotics into our country. Once you are a vetted NGO and you filled out your paperwork and you're coordinated through our system, you will come to a distributing center and we will give you the narcotics that are on your formulary, and then all the standards or chain of custody stuff applies. But from our standpoint, it was hugely helpful because we went through the process, we got approved, we showed up in country, and then we got these controlled medications, which would have taken 5 days to get out of the country through the DEA process.
That's interesting. Do you want to backtrack a little bit, or I can, and talk about the whole EMT movement and the meaning of that kind of for health response in these situations? Are you interested in that?
Yeah, sure. So, yeah, I think it's great since we talked about Haiti. So in the aftermath of the Haiti response, a lot of big brains from the public sector and the private sector and NGOs, government agencies came together and said, we need to do better. And one of the things that was born out of this was the EMT process, which is the emergency medical team process. It used to be called the foreign medical team, the FMT, but not the EMT. And it was a process spearheaded by the WHO to create standardized minimum baseline standards for teams that deploy, so that it would allow a few things. One, it would allow countries to have more autonomy in controlling who comes into their space when they're responding to a disaster. So they would be able to look at a menu and say, here's the capability of an EMT type 1, which is outpatient care, or an EMT 1 mobile, which is basically outpatient care. Here's the capabilities of an EMT 2, which is a smaller facility that's more mobile, that has some surgical capability, some holding capability. Here is the capabilities of an EMT 3, which is basically like a fixed field hospital. And classic example is Israeli Defense Force. They have a big EMT 3. And so it allows the countries to control what their request is, to know with some degree of standardization what's going to come into their country. That helps NGOs because it creates minimum standards to which they can develop requirements and then source those requirements. They can develop best practices in terms of both equipment and training and staffing and processes. And so the process really got going in 2014, 2015. Team Rubicon was the first NGO in the Western Hemisphere to get the verification as an EMT1 mobile. And it is a exceedingly comprehensive and somewhat painful process. But overall, I think is a good way of standardizing the response base. Now the challenge I would just say is that with any kind of standardization or any sort of large organization taking control of response, you do lose some speed of response and you lose some flexibility potentially. And so I think where the EMT process needs to evolve to is the ability to get modified teams in faster, or to get teams in countries faster. And again, this would just be a good case. We're pretty fast, but our EMT 1 wasn't in country until September 6th. And we're one of the first officially invited NGOs to have a team on the ground, but it's still 5 days after landfall.
So basically, the EMT process is an attempt by world bodies, particularly the WHO, to pre-credential and to better ensure the quality of medical teams that go to other countries. Is that right?
That is right. So in bureaucratic speak, they don't credential and they don't certify, right? And again,
that's too complicated.
What they do,
they kind of do.
Yeah, no, it's too complicated for me, right? They verify that you've met the standard and that you can use the title of an EMT1 or an EMT2. But where that becomes important in theory is most countries have now created agreements with the WHO that if there's a disaster, their country will work with the WHO or their affiliate like PAHO to set up a coordination cell. And they call it the EMTCC, so the EMT Coordination Cell, that helps coordinate international response assets. And so if you want to go and respond, it helps that you've gone through this process because your requesting body now knows who you are and they know that you've met a minimum standard.
Right. So to change topics a little bit back to something you mentioned before, you mentioned that there's concern about infectious diseases. Can you be specific about what the concerns are, and are there any other major risks that you see coming up?
Well, so I'll just say that I have not heard that there are concerns in our briefing document. Infectious disease hasn't been brought up a lot. I bring it up now though because again, we've all been through this and we see what happens with water displaced population. So cholera is not endemic to the Bahamas, but you have a lot of people coming in and out. Hopefully we do not have another Haiti where there's a cholera outbreak. but also just, as bugs start to return, they're standing in water, you can see vectors, dengue, et cetera. I think the other threats we're still just, we've got probably another month left of hurricane season, so another storm coming in would certainly be a threat. And then the standard stuff that you would see as we start to do rebuilds. So I talked earlier about how this is a unique mission for us. We actually now have 78 people in the Bahamas. And so we've been doing route clearance and muck outs and house assessments and structural assessments. We're helping clean out a hospital today, which is a traditional domestic mission for us. So as people go back to their homes, and as they start cleaning and clearing, there are, heat stroke, minor trauma, infection, cellulitis, continued exacerbation of chronic diseases. These are all threats that are going to exacerbate as people start to return to the island and return to their homes. So I think that's, what will happen as we've seen. We have a pretty good communication monitoring strategy. So we've seen the publicity for Dorian and the web traffic, web hits, social media has gone from, several 100,000 down to, about 10,000 a day in terms of hits and interest. And so as the interest wanes and as all these responders go home, I think we'll see a second wave of sort of medical issues. And so there'll be that gap as there's an escalation of medical needs and international interest starts to decline. That's where I think there's a threat.
That's a very good point. So given that...
I just realized I took hand gestures and you can't really see my hand gestures. So.
No, we're looking really hard though.
It was just like Top Gun. I was like, hands across inverted.
Given the extent of the damage, I mean, it's just amazing how much people lost. What's the mood of the population?
I mean, it's mixed. Again, having not been there, but these are certainly questions that we ask our teams. And so the medical teams, when they go out there, the people who are still there feel lucky and feel blessed, and they're tired because many of them are responders, physicians, health staff who stay in the clinic, and so they're exhausted. They're a little nervous because many of them haven't gone and done assessments on their own homes. I think there's some degree of sadness. I think there's a fair amount of hope. What we have been hearing, though, is in certain areas, there's frustration and anger, and I haven't seen a ton of this, but I know that there's some security issues in terms of just, escalations of petty crime and maybe some riots. And I don't think that any of that has scaled. But I think that people are doing the best they can. And the comments that we've gotten from people, from officials in the government down to locals that we're just having conversations with and checking their blood pressure is, thank God you came. Thank God you're our partner and our friend. And the sense of commitment to getting through this together. And our teams have all encountered really, really gracious and hopeful people everywhere they've gone.
That's great to hear. There's a long road ahead for everybody, though. So in the disaster response world, there's all kinds of new exciting things happening in regard to technology. Are you guys finding any new technology or interesting stuff your group is personally using, or that you've seen on the ground that's interesting? Or even all the social media stuff you already mentioned has become a valuable tool for monitoring disasters. Can you comment?
Yeah, absolutely. I would say, again, one of the unique things about Team Rubicon, part of this from our connections within the military and leaving and our understanding of the technology that's frankly been utilized in national security spaces, and then part of it is we have a pretty strong business connection to the private sector. We are pretty tech enabled, and so what's been helpful for us is the utilization of redundant communication systems. So we have sat phones and BGANs and Wi-Fi and dorms, and we have PACE plus communication strategies. So that's very helpful, and our partners have been great. We have partnerships with some of the now private sector satellite companies that are able to give us extra real-time satellite imagery, which helps us when we do assessments and when we're tracking what our mission profiles will be. But also, it's a great asset that we can hand to, Ministry of Health and say, well, here is what it really looks like on the ground. And then we use some other analytics internally that help us create value assessments of what we're doing. The other technologies that are, I think, personally huge, we deploy with we deploy with solar, so all our teams can be off the grid with Goal Zero generators and solar panels. We deploy with pretty aggressive water purification, and we now actually have some portable desalinization kits, which become huge for wash and for medical care, but also just health. We have clean water. And then the sexy stuff that we have trialed out in the past, and I think have a role somewhere, the UAVs. We're not currently doing any UAV stuff.
That would be drones.
But I think, drones. There's the UAViators Network is a nonprofit group that has been trying to craft these best practices and industry standards for how you utilize drones in disaster response. And I think, in a situation like this, there's huge potential in terms of doing damage assessments. There's huge potential in terms of transport of equipment or medications and supplies. We're not doing that at the moment. We've talked about using it again to some degree. We did deploy it in Nepal, but I'd say the biggest challenge for anyone listening is, anywhere outside the U.S., there are different rules and regulations for who controls airspace, and local security forces of whatever cloth and creed don't necessarily like UAVs flying in their airspace. There's some best practices out there. So if people are thinking about utilizing it or interested in it, UAViators, I think, is a group that's sort of leading the charge on that. I think that those are, and then you mentioned social media. We have a full-time team called it's MARCOM, which is our communications team. They track social media in order to figure out how we position ourselves, but they use the same tools pre-disaster or peri-disaster to track reports from the field to get an idea for situational assessment. So leveraging to some degree social media to get better situational awareness is something we're working on getting better at as well.
One of the difficulties.
What do you got? What other cool tools do you have that we can put in play?
I'm too old. I'm too old to do toys. I'm just a field responder.
I've got smart millennials to do it. Yeah.
One of the difficulties is that this is an island. We struggled after Haiti and after even Puerto Rico and Maria with supply chain and logistics. I know that the DoD is committed quite strongly to both air and sea deployment, and the British Navy has also. Have you got any inside knowledge about the logistics issue?
Yeah, I have some, but I think there are probably some better experts on the line. But I'll give you some thoughts. So the Bahamas is a relatively wealthy nation right off the coast of the United States, and they've got a lot of ties to the U.S. And we do a lot of business there. And so what filled the gap, or what has filled the gap, I sent one slide that had like 9 different helicopters on it because I thought it was funny, just all the different air assets. What we found is there are all kinds of businesses, Napa is an example, and there are other businesses that have supply chain and resupply mechanisms in place to go to the island already. And so that and many of these groups were just volunteering their assets to help with the response. And so it came to the situation. I mean, do you know somebody who works for a company who's got a ship going over there? If you do, you can get all kinds of stuff on their boat. So I think that ultimately a lot of that private sector logistics was slowly sort of creeping into the coordinated public sector response. But I think it's something that can be utilized much more effectively and proactively. And it's a great area to engage with the private sector and these public-private partnerships and say, hey, like UPS and DHL do logistics for a living. Can we have plans in place where if something happens, we just turn those logistics trains into some, give us 1 out of 7 flights for responders and 1 out of 7 flights for wash and meds and tarps, et cetera, and utilize the experts rather than trying to create something new. The British Navy has gotten great accolades from our team, and the Coast Guard as well. And they'll be great government-to-government partners. But again, the time it takes for Ofsted to broker the deal, the time it takes for Ofsted to authorize DoD assets to fly, sometimes things could be done a little faster, and I think they just need a way of combining all of those to be effective.
That's great to hear. That's been a big movement in the U.S. in particular, leveraging private sector logistics. I'm glad it's happening there. Along those same lines, communication.
Yeah.
The damage is so widespread. One of the first things that happens is the cell towers all get blown down. What's communications like down there?
Yep. Yeah, communication's been terrible. So even and it's a little, I'll just like, this is lifting up the hood, be completely transparent. I mean, I just said we deploy with BGANs and sat phone and multiple cell type capabilities. And even on Abaco, we were having trouble with connectivity. But I think that their process moves around that can improve it. And yeah, the flow of information from the field to the command center in order to coordinate mission sets appropriately was certainly a huge challenge here. And it is one of our AER points to figure out how we can leverage what I think are best-in-class resources to be able to do that better.
Interesting. So we're going to move to the open question soon, but I have one more for you. Funding. So far, the U.S. government, according to the USAID report from yesterday, has spent or is dedicated a little over $10 million to this. 3.5 from the DoD and the rest from OFTA. Where do you guys get your funding from to respond to events like this, and how are you funding this event in particular?
Yeah, we get it from very generous individual donors, corporate donors, and from foundations. So this number maybe has changed a little, but in general, our ballpark is we take less than 1% from the government. And that 1% is like we do wildland firefighting with the Bureau of Land Management, so we get some funding for that. But otherwise, we're all privately funded. And so in this particular case, we have a great development team. Jake Wood, our CEO, is an excellent speaker with passion and knowledge, and is a tremendous leader. And when he lays out the case for why we need to be getting our teams out there, people believe in it. And the fact is, our teams, it is the dual purpose of helping veterans serve again, but also this commitment to serving communities. And we have been very fortunate that we have an extremely strong and generous donor base.
That's really interesting to hear, because most of the bigger NGOs rely very heavily on OFDA to write funds after an event. Are you still well integrated into the OFDA coordination body?
I don't know. Is OFDA on the phone?
Yeah, I'm trying to avoid politics.
I think. So look again. You know me, Tom. Like, if nothing, I'm honest and direct about stuff. I think, and sometimes to a fault, but people can then at least know where I stand.
You're an emergency physician.
I think in the early days, in the early days of Team Rubicon, we would run and gun a little bit to the detriment of best practice collaboration with other organizations. And by early days, I mean like 2011, 2012. In the last 5 years, we've completely professionalized and changed our model. We're still fast and nimble, but we understand the importance of the system, and we try to help the system be more efficient. We've had some good meetings with OFDA in November. I'll just tell you again, one of the challenges that we have with OPTA is we don't need their money in general. And so the conversations have largely centered around how do you interact with a group like ours when we're not asking for money. And again, a classic example is OPTA, as you know, it's the USAID, and OPTA is the lead federal agency for U.S. involvement in international disaster response. The DoD often provides air assets. We often have people who were DoD air traffic controllers or helicopter pilots or know the ground or air commander on scene. And we have people who know how to load helicopters. And so we have a lot of things that can help augment and speed that mission set. And the trick is to facilitate good ground collaboration so that we can execute the mission more efficiently.
That's interesting. So your organization operates more along the models of Médecins Sans Frontières than a lot of the other big American NGOs then.
Wow. That was a loaded question.
You don't have quite the hundreds of millions of dollars they have, but they remain very independent.
We don't, but yeah, we don't have the millions, but in a lot of our fundraising is targeted because of our extensive domestic mission set. I would say the interesting comparison. I'm gonna have to figure out the MSFPR comparison. There are a lot of MSF people.
We can let that pass. That was just an observation.
But I think the independence and neutrality component of it, we're committed to. I mean, we've committed to the humanitarian principles as an organization. And for people who just hear Team Rubicon and veteran, a lot of times, not a lot of times, sometimes they're not able to distinguish the fact that veterans are not active duty military. Veterans are citizens who, at some point in their life, served our government in the military. But we're all civilians. And so sometimes when they see veterans, they think military, and then they think there's no way to be neutral or independent. And for us, it's on us to tell that narrative about why we are service oriented and why we are committed to humanitarian principles and why all of our operations, that's the core foundations of how we do our work when we head out the door.
Great. Do you mind if we turn to some questions from the audience?
I would love it.
Okay, so the first question is, how big was your scout team? How did they get there, and how did they pass the storm? Were they on ground during the storm?
The team that went to the Bahamas got there on the 2nd on a non-commercial JetBlue flight. We have a partnership with JetBlue. We've had on and off partnerships with some other airlines. And so that was how our scout team got there. This one had 3 people. It had a physician. It had our deputy director of field operations, Dennis Clancy. And then it had a team lead who basically helped to set up the forward operating base that would coordinate with the Ministry of Health. So our normal size is 4 to 6 people, and we're actually reassessing that right now with the balancing priorities of 1, we do not deploy full medical teams, and we do not conduct medical care in countries without permission of the ministry. With 2, we want to have capability on the ground so that we can perform assessments both for our own teams, but also for the ministry. And if there are emergency situations where the ministry instantaneously authorizes us to provide care, we have the capacity to help augment while our full EMT1 is deployed behind us.
Great, thanks. Next question. You mentioned that the government had already done outreach to dialysis and some chronic disease patients. Do you know how they did that? Is there a registry? Do they use local health providers? Do you have any details?
I don't have details. No, I don't know how they did it. I just know from our teams that when they had the conversations, they were told that the government has a list of everyone who's on dialysis in the Bahamas, and they evacuated most of them.
Yeah, that's a model that U.S. has really picked up in the last 5 to 7 years, where dialysis patients are tracked and everyone knows where they are, and people pre-position dialysis.
Yeah, I mean, it was a huge issue last year domestically in North Carolina when we responded from a medical standpoint. We had to helicopter dialysis patients out of Burgaw, North Carolina, because they were there 5 days of dialysis and we were getting up soon. So I think it's a great model to preemptively save a lot of money and resources on the response.
Yeah. You had mentioned long-term problems with chronic disease management. Do you know what the commitment is to that going forward? Do you know what the capacities are of the Bahamian government and the local providers?
I think they're committed to treating it, and honestly, I think they'll be fine once resupply chains get back up. I think the biggest need in Abaco, which again, like a lot of people think is not sexy in terms of responding agencies who want to kind of fly in and do really cool stuff, is most of these clinics are functioning at, call it 80 to 90%.
Huh.
But what they need is they need a nurse or a doctor or an FP or a nurse practitioner who can come in and provide 3 days of care and a couple days of extra medication so that their providers can go take a nap.
Right.
Yeah. They've been working for 5 days straight. They don't know where their families are. So what they really need is surge support. And they will need, they'll need resupplies of medicine. But I think that's happening right now. What we saw in the gap in the sort of first 5 to 7 days is people who, lost all their metformin in the storm, and so they're 5 days without metformin, or they lost all their antihypertensives, or they're, 5 days without antihypertensives. But a lot of what we saw were well-checked chronic diseases. We did evacuate maybe 5 or 6 people in coordination with different air assets, but they were things that were not storm-related. A status epilepticus, an appendicitis, and there's a psychiatric patient, and then maybe I don't remember the other two. One was a ped with respiratory distress, which could have been storm-related or it could have just been bronchiolitis. But so I think that they're going to be able to, from the meds and supply piece of it, their fixed facilities are in decent shape. They need to get back up and running. I think they'll be up and running within the next couple weeks at full capacity. And then they'll just need some surge support as they start to repopulate the island, and as they start to see these populations moving again back into their homes. Because right now, you got to remember they're taking care of 10% or 20% of their normal population. So it's easy to be at 90% capacity.
Oh, yeah, right. So do you guys have a formal field hospital established, or are you using more of a mobile approach? That was unclear.
Yeah, we do mobile. We do mobile medicine. So we are operating, let me rephrase that. So the EMT1 mobile team, which is one of our capabilities to deploy, is a mobile team that's able to go out and provide 12 hours of care, so basically sun up to sundown care, treat 100 patients a day, be self-sustaining for 14 days. We have tents that we set up for patient waiting and treatment areas, and we have a way of doing private exams, but these are mobile. Now, that can be converted into a fixed clinic that does mostly primary stuff and some emergency stabilization if the request is there, or it can move into a fixed structure and provide care out of there. We have capacity to do that. And then the final one is we'll sometimes provide the EMS mobile type capability for a fixed facility. So if someone sets up a field hospital, our teams can go and provide mobile care out in different communities and then service referrals back to the fixed facility, and then can also assist with transport of patients.
Are there fixed facilities that you're aware of, and who established them?
So yeah, on Abaco, I think they've redeployed today. I'm not 100% certain, but there was an EMT2, which is a fixed field hospital at Marsh Harbor that may have redeployed today to Grand Bahama. And then
that was
Grand Bahama,
Samaritan's First?
Samaritan's First, to my understanding, had an EMT2 capable facility. And then there's one other on Grand Bahama, and I'm not sure who the organization running it was.
Are there?
But the two main hospitals on Grand Bahama, I think, are more or less functioning now.
So are there I'm digressing from the written questions here, but outside of U.S. NGOs, have there been other NGOs that have shown up from the international community to respond either in any of the clusters, water, sanitation, and health?
Yeah, probably. I don't know the answer. There are a bunch of NGOs that I don't know who have shown up for the med piece of it. Team Rubicon UK. The Team Rubicon has affiliate branches in the UK, Australia, Canada. The Team Rubicon UK has responded, and they do a lot of wash work. And I'm sure there are some other NGOs within the other sectors that are international. The predominant response has been U.S. based, though. Just I think largely because of proximity.
Yeah. There's a question from the audience also about the DEA narcotic issue. That's very interesting to me. I'd never even thought of that before. Are you aware of other countries or other issues with narcotic transport in the past? Has your organization had any difficulties?
Yeah, I mean, we haven't been able to. So when we're in Mozambique, we're not able to bring. This was the spring. We're not able to bring narcotics. And so the process, as I understand it, and again, if there's an expert on the line, please contact me afterwards. So it can be more efficient. But the DEA requires a letter from the host government stating that they accept the specific formulary of controlled substances, including numbers of the medications that you're bringing in. You then take that form, you take that letter, there's a form you have to fill out that has the exact same information, the carbon copy triplicate form. You send it to the DEA disaster response email. They have one that's for domestic, and then they have one for international. And then they respond and authorize you to leave the country with it. In my experience, not to knock the DEA at all. I've had conversations with some people who say, we'll turn it around 12 hours, just get us the stuff. And then there are others that said it'll take 3 to 5 days. And so it's a tough process for us to rely on. And they won't let you do it preemptively, even though we have a standard stock and same thing every time we go out the door. So you can't have something that's sort of online with them that as soon as you get the letter from the other country, they just push a button and say, here's your letter, go. But it's the government, so I don't give too much credit for it. But it is a limitation for us if we want to provide immediate care within 12 to 24 hours of disaster, and it takes us 3 days to get our narcotics. That means that we can't send it on our first wave. We can't send them with our recon team. So we have to figure out another way to get it in country.
Yeah.
Again, I'm sure there's tons of people on the line who are like, let me tell you how you can do this. And again, contact Tom or send me an email. I'd love to crack the nut. Big dumb animals. So whatever. We don't waste people's time with it, but please contact me if there's a better way.
We're running out of time, so let me do one last question. It's a specific question about behavioral health. Is Team Rubicon involved in behavioral health aspects of this response, or are they aware of the efforts on the ground?
No, we are not involved in it. We have behavioral monitoring and wellness for our own teams, both assessments, pre-deployment that probably could be better, assessments and wellness activities during deployment, and then post-deployment wellness. But we do not, right now, we do not provide behavioral health services beyond emergency behavioral health stabilization. So if someone's having a psychotic break, we have medications that can help stabilize them while we move them to a fixed facility within the response system. So just like an emergency department, we're capable of handling emergent psychiatric conditions, but we haven't built out the capacity to handle broader, more routine, and maybe more simmering behavioral health issues.
Great. We're out of time.
There are other groups that do it much better, yeah.
I really appreciate your comments. I think this was incredibly insightful. I just want to remind everybody that this disaster is truly devastating. The current death toll is only listed at 50, but there's still more than 1,300 people missing. With the level of wind damage as well as the storm surge, the death toll could climb dramatically. So keep the Bahamas in your mind, and make sure you support the response in any way you can. Thanks again, Dave. I really appreciate it. And we'll be posting this webinar online so that people can review it and make sure you spread it widely.
Thanks for the time and the opportunity, Tom and Alice and the team. Really, really appreciate it.